This meeting is being recorded.
Hi, everyone, and welcome. We appreciate you taking time out of your day today to join us for what's sure to be a very lively and interesting discussion related to a topic I'm sure all of us care deeply about. We are hosting it today as Innovaccer, but we are actually here on behalf of the healthcare community because this is a topic that spans so many parts of the ecosystem. So many people are, in fact, working on it. And here with us today is going to be a set of physician leaders who have spent much of their career, if not their entire career, working hard at figuring out how we can bring a much more equitable approach to care and wellness across the United States. I'd like to start and just give you a quick overview of Julio Albano from Prisma Health. He is our Chief Medical Officer. He is a family physician who is also certified in sports medicine and a university professor. So he is not only taking care of patients, he is also teaching the next generation of clinicians who will be, in fact, taking care of patients in different ways. I'm Amy Stevens. I'm the general manager of Innovaccer's provider performance and transformation arm, working very closely with providers and risk-bearing entities, health systems, payviders, who are looking at how the new models of healthcare can be supported with digital. Dr. Anil Jain is here. He's our Chief Innovation Officer. And when he speaks for the first time, he'll give you a little bit more about his background. And Dr. Brian Silverstein, who is our Chief Population Health Officer as well. So welcome to all on the line. We would like this to be more of a discussion, and I know that can be tough from a technology standpoint, but if you can put a note in the chat, we would love to hear from you. If we're able to even break you out of mute, we'd also love to hear from you just piping in. And what you'll note is panelists will also ask each other questions. We are not here to have a one-sided toss the ball back and forth. So with that said, I'd like to give a little bit of place setting on how we are thinking about health equity, recognizing there's so many different definitions out there, different ways of approaching it. We're going to talk about it in three primary ways: as a structural situation, if you will, a structural norm and culture that exists within the world, and in particularly within healthcare, and how those structures at broad macroly sat and thought about and challenged and thought about how we can unstructure them. The next part of the conversation will be about Health 101, which is the person level. How are we, in fact, bringing equity at the person level? And then we'll end by talking about how do you scale? And how do you innovate so that individual programs, individual initiatives, things happening at one health system but not another, can start to become standardized, systematic, and predictable in a good way to get over the structural issues that are impacting us in negative ways. To start us off, I'd like to put up this quote that was offered by Dr. Ansel from Rush University in a really interesting study and book that ultimately came out of it related to health equity in the greater Chicago area. But we're really attracted to this definition because it talks about more than access. So many times in healthcare, access has been the key linchpin. And sort of if you solve the access problem, everybody would just be able to get care. And everybody would have access to the services they need to keep them well, when in fact, it's really about opportunity and having equal opportunity access so that in the end, you can be healthy and not just cared for. Related to that same study, and it's one of these great examples of structural, is in this same Chicago area, they found that if you were to take the Red Line train, which happens to go north and south in the Chicago area, and went from one end of that train line to the other, that 30-mile span would change a person's life expectancy by 30 years. And the area in the box, which is a very short, it's only a couple mile throw, really, that area would change your life expectancy by half. Fully 50% of all that change occurs just in that one boxed in area. And so even though they are in the same city, literally riding the same trains to work, and to doctor's appointments and to other activities, these same people have a radically different opportunity to live in a healthy way. When we think about what is causing that type of disparity, we know that there are a significant set of factors sitting in those yellow bubbles that are structural issues that have created over time, well outside of healthcare, and have permeated our society in a variety of ways. But then you have to think about, how do you break those apart so you can actually start addressing them? How do you turn them into specific characteristics that can then be addressed in an actionable way? So we think of these things on the right, everything from education to transportation to the social factors that are determined. And as we look today about that are being applied, the different uses of technology, we'll talk about how they may in fact affect these blue bars of social determinants. I'd actually like to turn the mic over here to Dr. Silverstein to take us through this first section talking about structural inequity. And Brian will give you a quick debrief on who he is as well.
Absolutely, Amy. And so really an honor and a privilege to be able to have such esteemed panelists and have a conversation here. You know, it's interesting when you think about health equity, it clearly is one of the hottest topics right now. And the way that I look at it, though, is that we're giving better nomenclature and drawing attention to something that's been an issue for decades, if not likely much longer than that. And part of the way is the way that you really think about what's happening in terms of structural inequity. And you know, the definition of this refers to where you have a systemic disadvantage of one group compared to other groups, and it's deeply embedded in the fabric of society. But when you really make that into a simpler version, what you realize is, based upon factors other than patients' clinical conditions, they have dramatically different outcomes. And this is a challenge for all of society. In today's world, where a vast majority of the world is fee for service, then the challenge doesn't, I think, get as much attention as it should. But as we start moving into a whole host of value-based contracts, then I think we're going to see more opportunities where doing the right thing for patients is ultimately going to lead to better clinical outcomes as well as better financial outcomes. We want to add into this slide, you know, the other things that we're thinking about here in terms of structural inequity is really thinking about what are the different ways that we could look at a patient differently and recognize that oftentimes there needs to be a behavioral change. Sometimes it's based upon social circumstances. Sometimes there's different ways of looking at it, at a problem. And I think food and nutrition is actually a very common example, especially with patients with various clinical illness. They might not have access to foods that are appropriate if they have congestive heart failure. They might not understand what low sodium is. Someone might have, I can assure you, when they go to the doctor, every single time they say, hey, you should follow a heart healthy diet or a low sodium diet. But what does that actually mean when you go to the grocery store? What does that mean when you're cooking? And how that then ultimately impacts that patient's clinical condition and what's occurring to them. We go to the next slide. So the way to kind of fundamentally take a step back here and say is that I believe that when you look at some of the value business models, there's actually tremendous opportunities to put resources in addressing the health inequities. And in addressing the health inequities, it's going to get better outcomes. There's commonly this whole notion of this is just yet again another unfunded mandate. And unfortunately, in a fee-for-service world, to some extent it is. However, when we start really thinking about value care delivery and value contracts and being paid on outcomes, then that's where some of these business models can work and there will be enough money. We keep building the slide in, please. Then we also say, hey, we can't get paid for it. And that's true today. In many cases, you can't get paid for it. However, when you move into full risk-based contracts, all of a sudden now you do get paid for it. There's great examples, for example, where organizations take Medicaid full risk and do food pantries. And just by doing these food pantries, patients have a very different experience clinically that leads to better outcomes. In addition, there's a number of models that are specifically being developed or have been developed, being implemented, that are addressing health inequities. And again, this is something that's existed for a long time, but now we're drawing attention to it. And by drawing attention to it and focusing on it, it gives us that opportunity to really make a difference. And we continue to build the slide in. The other thing that certainly we hear is we don't know what works. And this is a great example of until we try something, we're not going to know what works. And what we're dealing with here too is quite complex. And if we don't collect the right data and don't have the right information, of course, we're not going to have the right outcomes. And so we're in this opportunity now to do a lot of trial and experiments, test things out, see really where we're getting outcomes and enhance those. And where we're not, then try something else. And I think that's really one of the key messages here is that don't let good be the enemy of great. It's thinking about how can you focus. This next graphic is highlighting for you. Actually, we recently did our customer conference and 3 of our customers are deeply focused on health inequity. And the reason is because they're in a variety of different contracts that allow there to be clinical and financial opportunities by focusing on it. I'm just going to share with you a snippet of each. The first is a health system. And so they were looking at how are different ways that we could look at transportation, access to care. And what they did is and like I spoke to earlier, some of this is creating a food pantry. Some of it is about transportation. And it might seem so basic in terms of transportation, but what you realize is if you're in a situation where perhaps you're not as technically savvy, and perhaps you have mobility issues, so you can't take a standard Uber. You can't rely upon some of your family. Don't necessarily have friends who have transportation or cars. Getting to that appointment is a problem. And what happens commonly is I'm going to sit around and wait until, when we have a situation where it's critical, I'm going to call 911. And that's the worst scenario. So being able to think about how are different ways that we can create those access barriers. And that's what this health system is doing. I'm really hoping they're going to get some great results. The next example is looking at another entity that's a risk-bearing entity. And so as opposed to a health system that some of their contracts are risk-bearing, the risk-bearing entity is formed purely for this. And in doing so, they're really focused in on those social determinants of health needs and access. And what they're doing is ensuring that they're collecting the right data regarding behavior and then thinking about different interventions that they can have so that they can actually determine the behavior change and outcome change and segmenting the patients based upon their needs. And so really excited to see how that's going to evolve. And the third is, again, another organization that has a medical home plus an IPA, an independent practice association. What they're looking at is women's health. And within this particular area, how can they bundle different care, combining different things together? What are different ways that they could also think about community support? This whole notion that we need to have a healthcare expert engaging with patients. Oftentimes the expert doesn't know how to relate to patients. They're going to know clinically what to do, but they don't actually speak in a way that a patient can hear. And so how can we engage members in the community and train them from the experts' concepts to implement them, and also ensure that people are getting referred to local resources, because those are just a lot easier to access and get these outcomes. You want to move on to the next slide, please? I think we're going to, at this point, turn it over to Dr. Drew. And Dr. Drew, we're really honored that you're joining us. I know that this is top of mind for you, and you're actually focused, you're moving in a very significant way towards risk contracts and thinking about how this could tie in, and would love to hear some more.
Yeah, thank you, Dr. Silverstein. It's great to be joining you and Dr. Jane and Amy this afternoon, and certainly a big thank you to the audience for carving time out of your respective schedules. We know how important this topic is to us, and I imagine the same applies to everyone on the call. we look at the slide in front of us, as Amy mentioned at the introduction, I serve as the Chief Medical Officer for Population Health Management for the Envio Clinically Integrated Network under the umbrella of Prisma Health. And I also have the privilege of serving as the Quality Officer for our primary care across the enterprise. And so with those two lenses, it's really eye-opening to look at opportunities that exist not only regionally here in the upstate and Midlands of South Carolina, but certainly regionally and nationally. And so that's where partnerships like this with Innovaccer really help us to have a greater scope of influence, and hopefully some of the things that we're going to discuss today will help you in your respective roles with your organizations and in your regions. And so when we look at Prisma Health, it's a private nonprofit health company. It's the largest healthcare entity in South Carolina. And as I mentioned, within that umbrella, we have the Envio Clinically Integrated Network. Within the network, we have 5,200 employed and affiliate clinicians spread out across the two geographic regions mentioned. And our footprint helps us to capture 1.5 million unique patient visits annually across a 21 county market area, which essentially covers 50% of the population in South Carolina. So when you look at it, we're covering 50% of the geographic region of South Carolina, excuse me. And so when you look at it, we really have a tremendous responsibility, but a tremendous opportunity in front of us. And so when we look at health equity needs that we're focused on, and I have the privilege of working with fantastic teams here, we're looking at health literacy. Certainly, that's a cornerstone, I think, of us moving population health forward. We want to make sure that patients understand the care that they are recommended to receive, how they best align with management of chronic conditions, preventative strategies, and again, that all starts at health literacy as the core. And so that's where we think that there's great opportunity, at all ages and all facets of life. It's never too late to learn something new about ways that you can better your health. We also look at decentralizing care. And so when you think about traditional models of healthcare, certainly, the healthcare systems, the clinics, the tertiary centers, they've been at the center of the care. And so what ends up happening is that patients and their families end up having to disrupt their lives and their schedules to seek care. And so obviously, as we've seen with the COVID pandemic, utilization of asynchronous resources, virtual resources have helped to shine a very bright light on the opportunities in front of us to decentralize care, to be less of a disruptive force, but more of a complementary force in patients optimizing their health and their overall life satisfaction. We're also looking at technology access. I know that one is very hot button and very applicable to the conversation today. Certainly when we talk about inequities in healthcare, I think technology access is a big one, and one that we would need to curb in order for patients to better align, goals with the treatment plans that they're being presented with. Certainly getting, resources that can affect and improve the barriers that come up from a social determinant standpoint. So when we think about, adherence to medical therapy, from access to certain ancillary services like physical therapy, occupational therapy, when we think about, just basic, safe spaces for exercise, like having technology in play allows folks to readily access those resources and be able to locate resources when they're available in the community, because we know a rate limiting step to the patient's success is not necessarily not having the resources available, but it's just not knowing how to access. And so I think technology helps to bridge that gap and serve as a very appropriate conduit to care. And then the last two listed there, you can see expense reduction. I think we could all agree that, and as Dr. Silverstein mentioned in a previous slide, our capital expenditure for healthcare is extraordinary and compared to other advanced countries. But unfortunately, our health outcomes don't really mirror that investment. And so obviously there's tremendous value in trying to reduce the overall expense, certainly at the individual level, but certainly and as well as at the macro level. And then engagement and trust, I think, is really at the core of what we do. And so, patients and their families come to us as healthcare professionals. They're seeking our expert opinion and guidance in trying to optimize their health and health outcomes. And really what we need to do is really optimize and emphasize the importance of trust and engagement. So that way, all the other things that were touched upon, can be successfully completed as long as we have trust at the center. And so with that being said, what are we doing and capabilities that we're building on? So, like I said earlier on, I can't take the credit. I'll certainly take the blame, but I divvy the credit to my teams around me for the success that we're achieving. But some of the highlights here, so we're utilizing, the entire healthcare team. And so one of the things that we really want to look at is moving away from the commoditization of our healthcare team. So just because somebody is a provider or a clinician doesn't mean that everybody has the same skill set, same education level, experience level, but it means that they bring something unique to the table and unique to the experience with the patient. And that's what we need to really showcase, is to say that everybody's role is vital, but not everybody's role is the same. And so what we're looking at are ways that we can leverage individuals like community health workers to help navigate patients through the resource pool that is available to them, to help them execute on the treatment plans that have been outlined by their clinical teams, and to help put them in a position of success. As I mentioned previously, leveraging technology resources and partnerships. Obviously, we have a great relationship here with Innovaccer to help from a data analytics side, and helping us to connect with other partners in the health tech space. And so that's a big piece of the puzzle, right? Is to say, how do we best position the resources that we have available to us, or maybe resources that we haven't tapped into yet, that are going to help us better do our jobs, right? And better set up the patients to be healthier in the future, right? And so when we look at all the technology that's out there, we have to be mindful that at the cornerstone of the solution is making sure that the patient is not limited by an absence of that resource. And so that's something that we're obviously working on from behind the scenes, to say it's not just good enough to put a device in a patient's hand for remote patient monitoring or to conduct a virtual visit, but it's, how do we make sure that they have reliable Wi-Fi? How do we make sure that if there is a technological issue, how does that get addressed from an IT support standpoint? So again, as we touched upon prior to the meeting starting, IT is not my strongest suit. That's why I wear a stethoscope and maybe not a laptop, but at the end of the day, we have to make sure that those things are not forgotten in our journey to get patients to their optimal health. And then and the bottom two bullets you can see here, shifting that emphasis from revenue generation to expense reduction. And that's really the crux of the value-based care model, right? Is to say that we're not just going to be fee for service trying to get patients from today to tomorrow, but it's really saying, how do we set up patients to be healthy for the next decade, for the next 2 decades, et cetera, and also to have generational health, right? To say that we're getting patients off of this cycle of, that they're, unfortunately, that their family has a certain condition or a family history of certain conditions. How do we break that cycle and say, just because your great grandparents or grandparents had diabetes or hypertension doesn't mean that you have to suffer the same fate. And so how do we break that cycle and put patients in a position where, cost is not a rate limiting step, and that the value of the interaction, the value of the care they're receiving is really setting them up and the future generations, their offspring, et cetera, to be healthier. And then when we look at standardizing workflows to reduce variability, I think that just goes to the core of quality, healthcare quality and safety, right? So the less variability that we have, the better that we anticipate the outcome to be. And then that also helps us to level the field in terms of health equity. So that way, once an individual steps foot in one of our practices, whether virtually or in person, whether they interface with one of our clinicians, in the upstate, in the Midlands, we want to make sure that that experience is uniform, with the variability being in the person, right? So they may see a different smiling face, they may see someone with a different medical experience or background or degree, but at the end of the day, they're still getting that same level of care, and they're still having that same high level of experience that they come to know and trust when they interface with us. And then when we look at outcomes that we measure, these are all lagging measures of performance, but nonetheless, they are important. So we want to make sure that utilization and access are prioritized. So again, it's not a one-size-fits-all model, but a one-size-fits each person best, right? So maybe initially they need to see us in person, but as we get their condition under stable control, maybe their next visit is virtual, and then we cycle back to them being in person again in the future. Maybe it's something where they're doing facets of their care, like routine monitoring for diabetes or other chronic illnesses. They're doing it asynchronously. That information is being fed back to their primary care physician or primary practice, and then decisions are being made in conjunction with the patient, but maybe not face-to-face. It's maybe done asynchronously through messaging. We also want to look at equity across payment model. And so, for us, we really want to be agnostic to payment model. We want to look at it and say, how do we provide the best level of care for each patient, regardless of ability to pay? And that's something that we're always working towards. And certainly we want to partner with our payers, so that way we can leverage the programs they have in place, leverage the programs we have in place to position patients for their optimal health. And then certainly that just dovetails nicely into cost, and that, as mentioned earlier, we really want to be curbing costs as much as possible, knowing that that can be a significant limiting factor for patients and their families. And we don't want to put them in a position where they have to make a choice between several basic needs, right? Housing, transportation, clothing, food, healthcare. We want to make it where it's complementary, not confrontational. And then obviously, as I mentioned earlier, with trust and satisfaction, we want to make sure that we're optimizing the patient experience, knowing that patients are going to partner with us better when they know and trust who they're interfacing with, and that they know that we have their health outcomes, the best health outcomes we can have for them in mind. And that's what we're strategically always trying to position our patients for. And then I can't emphasize enough that even though this is the last item on the bullet here, the key here is if we don't position our healthcare professionals to be successful and to be well taken care of, then we really are not doing our best work taking care of the populations we serve, because they do fall within those populations. And a healthy workforce, our healthy colleagues are obviously going to be able to do a much better job than those that are suffering from the same challenges, restrictions, health inequities that we're trying to solve. If we're not focused on them, just like we're focused on the general population, we're certainly doing a disservice and hurting everyone in tune. And so what I would say there is that, a big part of the work that we're doing is how do we optimize our healthcare professionals to be able to do their best work and accomplish everything else that's listed on this slide. So with that, I hope that was informative and helpful, and I think it's time to turn it back over to Amy.
Incredibly informative, and I'm sure very helpful. And I'm going to ask for a favor from our team Innovacer. I can't read the chat because I'm doing the slides. So if we can have our Innovacer team shout out the chat questions so we don't ignore the audience, that would be awesome. While that's happening, I'd like to actually do a little bit of a follow-up, and this is really, I'll start with you, Drew, but throw it out to all three of our physician leaders here. One of the things that's striking as you look across this is how much the workforce, our own workforce, has changes ahead of them as they themselves experience health equity and are starting to understand what that means for it's a generational of patients differently. And one of the things that often comes up is the who's going to be in that broader set of care team members that we may not have seen before, and how are they engaging with patients. So I'd love to hear you talk about what you're seeing as clinicians as the care team sort of demographic or composition is changing, the types of new roles we have, the types of expertise that's expected. Drew, you kind of teed that up here, but then Anil or Brian, if you have other things to add.
Yeah, sure, Amy, thank you. And I think I heard the entirety of your question, so it just sounds like we had some technical difficulties, but you're looking at the novel ways that we're better utilizing the entire care team versus some of the traditional models, which would maybe be physician and nurse, et cetera, or medical assistant. So yes. One of the key facets or initiatives that we're looking at here is better leveraging our pharmacy colleagues. So our individuals with a PharmD background, so a pharmacy degree, and basically looking at ways that they can help with different facets of care, like we think about for Medicare recipients, their annual wellness visits. And that's a great opportunity to complete the health risk assessment, making sure that we're looking at some of those social inequities or social determinants. We're also looking at ways that we can better position patients for end-of-life care, right? So we're making sure that we're doing the advanced care planning piece, which is, I think, the first two items on that health risk assessment. And so that's one example where we're better utilizing our pharmacy colleagues to help. They're also providing resources both in person and virtually. So we have patients that may be on more complex medication regimens. So maybe they're on biologic agents, or maybe they're on a more complex regimen of anti-hyperglycemic agents. And so for our initial healthcare team, whether that's our clinicians, our physicians, our APPs, it may be a little inundating for them, especially with a pretty robust schedule. So it can be very helpful from the PharmD to lend their expertise and say, we just need to be mindful of this potential interaction, or we want to be thinking about maybe using this medical therapy instead of this one. And so that can really help to position patients for, better health outcomes and certainly improve safety. Other things that we're looking at, certainly using medical assistance in ways like scribing for our physicians that can help cut down on some of the administrative burden. And I think that brings a lot of job satisfaction to medical assistants, in that they're not just rooming patients, but they're also helping to capture the medical history. They can help with completing certain questionnaires, like our patient health questionnaire for depression screening. So that's a great opportunity there. And then obviously we're looking at care coordination, and we used the community health workers as a key example in the slide previously, but those are just, I guess, some highlights that I would share in response to your question.
Yeah, Dr. Jane, you work at Cleveland Clinic in addition to working with Innovacer, and my guess is you're also seeing this next generation of clinicians coming up with new ways of being trained and thinking about the patient.
Yeah, I would just add to what Drew was mentioning that, there's a greater need for having members of the care team be more savvy with data, who can understand and review data and understand the patterns and then understand where resources might need to be applied. That's one element that we're seeing more of. And then the other one would be who as part of the care team is actually helping optimize the technology that's being utilized. Drew mentioned earlier that he's not an IT expert. Well, frankly, the problem is that all of us clinicians need to become IT experts because it's become very, very important. So how do we bring in the right members of the care team who are going to help optimize, configure, and create those workflows that are going to help reduce some of the burnout and help improve healthcare professional well-being? Because otherwise you really have a bit of a challenge. So whether we like it or not, all of us are in the IT field when we're clinicians working today. And yes, we may be better at our stethoscopes, but we probably need to be better with our mice and our keyboards as well. And so I think those are the two additions to the care teams that I'm seeing, is people that are more savvy with data and people more savvy with workflows that might be things that Innovacer does, or workflows that the native EHR vendors might require. So I'll talk a little bit more about that in a little bit, but that's what I see.
And maybe, and certainly, yeah, absolutely, Neil. And Drew, I really appreciated your detailed outlining of all of the various people. And so I think you were quite comprehensive in that. And I think what that highlights to me is this whole notion that, this has been an issue for decades, and we haven't had a solution that was a reasonable solution. And now what we're seeing is more specialized skill sets being able to address these individual issues and getting great outcomes. And one example that I think about is polypharmacy, and how many patients they get so confused with their medications, and having even a pharmacy tech go into the home and say, show me what you got. And all of a sudden, and you see the pictures of this, where literally like the kitchen table just fills up, and it's really confusing. And you realize why there's such poor outcomes then. And by focusing on this, we can really make it better. And where I do see these things coming together, although it's extremely early, is with a lot of the risk and value-based contracts. And when you look in the fee-for-service world, there really isn't much of an incentive. So it's clearly no one's doing anything nefarious and saying, oh, I know this is an issue, but I'm not going to address it. But it's more, we all have limited time and energy. And so we're going to focus the energy on the different metrics that we need to. And as these metrics change and we get better measurement, we're going to get these better outcomes. And associated with that, certainly, Neil, agree with you that we need to get more tech savvy, but at the same time, I'd love to see the tech get better. Make it easy. It's all of us, I think, can remember, for example, when you first wanted to videotape a show and you had to read the manual and it was blinking 12 o'clock and you set it up and it never worked. And now it's push button simple. And that's what we need to do for clinical care, is being able to segment patients, identify what's wrong, and have it be push button simple for the patient to at times self-service, or for people and the care team to understand what really interventions are going to help the patient out and monitor and track so we're getting these outcomes.
Yeah, completely agree. We do need to make it more simple, for sure.
Well, that's a perfect tee up to stage 2 of the conversation, which is to move from these structural tools, methods, infrastructure, to thinking about how do we bring those into workflows of, for instance, this extended care team in ways that at the moment they need it, they get the information that helps them make the right decisions and support that person, not the whole population, but that person at that moment, with what the patient thinks they need, but also what we might be able to see from a broader perspective, because we have insights and knowledge about that patient that could be helpful to them. As a quick cue up, thinking about how this bigger pool of data can be brought down to the individual level so that we have the right insights at the right time. Thinking about the BIPOC population, if we are looking at the population health level, and are thinking of women of childbearing age years and those that are maternal, we can see that the US is not doing great by international standards of maternal deaths. These are not comorbidities, these are deaths that are happening. We have the unenviable position to have dropped to the worst in the developing nations. And while that looks really bad as a whole, when you actually start to drill into it, it looks much worse when you pull apart those women who are Black, Indigenous, or of color. And if we look at just population health level, we often start to miss these nuances, which, for some would say is one of the reasons health equity has lasted or has persisted in the way that it has. And I'll give you some examples of what that looks like that is so striking. We can see how different on the left side the non-white populations are affected by this really epidemic of maternal death. When we got to the point where women, the number one cause was not childbearing, it was a major milestone in our country. And unfortunately, we are seeing that backsliding dramatically, and for the babies as well. Now, what does that actually mean? How do you use it? How do you find those women? Well, I want to give you an example where a group of, and what I loved what you said, Drew, earlier, was talking about your own workforce. Sometimes we forget just because they're employed does not mean they do not have health inequities or so these are employed people and discovered that they had very significant opportunities in the employed group of women around high-risk pregnancy and social determinants that were affecting it. And so the ability to then say, well, what could we do within that population to find exactly the right person at the right time becomes really critical because there's a 9-month window, and some would say a first 30-day or first 90-day window to have a huge impact. And what we're seeing is, how do people pull that data into existing processes or new tools and workflows in order to find that particular person once they now realize that there are different things happening in their population than they thought, do a lot of the work they have already been doing. Many of us already are doing annual screenings. We have portals that we have patients working in. We're doing referrals to community-based organizations. How do you pull it into one continuous place so that you see that at all times and all different parts of the organization, from marketing to the call center to the care team, is all understanding what that patient needs. And each of these interactions are being informed by new sets of data and new workflows that encourage for things, for instance, like community-based referrals, language sensitivity, multi-generational outreaches that might need to happen, local cultural norms, so that even though these are activities that we may have already been done, how are they being flagged and changed in an automated way so that that care team can be more effective? I'm going to actually take us off share for a minute and just ask a few questions about this before we move to our third section. And that is, when you think about these individual patients and how we're putting new types of services and insights in the hands of the providers, are there any particular metrics or flags, if you will, that you're seeing have been really effective to help that care team be more knowledgeable and ready for the patient and providing them a different type of care? Let's see, you're going to all speak at once. How about Dr. Jane?
Yeah, no, it's a great question, Amy. I think one of the things that we have to recognize is that not every social determinant of health is equal, in the sense that it all signifies different needs. And so one of the things that I've seen that works very well is to have a hierarchy. First, identify that this individual, there ought to be a deeper dive or a deeper discussion because something has been identified as a vulnerability. And then within that vulnerability, have another level of insight that doesn't require the clinicians to be hunting and pecking in the EHR or in a system for information that might be buried in someone's note 2 or 3 visits ago. Back to Brian's point, make it simple. Surface up the most important information as quickly as possible, but flagging the chart that this is someone that the clinician might need to spend a few more minutes with because they might be prescribing the right medication, but it may not be accessible, or they might be recommending the right type of treatment, but it may be difficult for the patient to actually understand. So the first thing I would say is that you flag the chart or flag the visit or the encounter with some sort of tickler that says you might need to spend a little bit more time so that the clinicians don't feel like they're overburdened and trying to squeeze everything into a single visit, but then very quickly identify the specifics of what is needed. Is it food insecurity? Is it housing insecurity? Do they need to visit the nurse's station to get some cab fare or Uber fare or whatever it might be? And so the first thing would be that you have to give a tickler that says spend more time and then go into the specific details. Whether it's an index, a score, a change in the banner color, there are different ways that I've seen it done, but the most important thing to do is train the clinicians to look for those so that they actually take a moment and pause and spend the time that they need with their patients.
Great. Those are excellent ideas. Brian, I know we've got some questions coming in through the share screen.
Absolutely. And by the way, please, continue to put questions in the chat and let us know what you're thinking. This is fantastic. And I'm going to just go through a couple of them just so that people can hear what some others are thinking. So there was one comment that someone made, and I've heard of this as well, is the health system they work with had EMTs do a home check for CHF patients and also did nutrition and teaching in the home. I think coordinating with EMS is one of the greatest opportunities. And San Diego's actually done this for quite some time. When they're not busy on calls, they actually sometimes have a patient volume that they keep track of, sometimes patients who frequently have access issues. And it's just amazing how, depending upon your local EMS system, how you can coordinate to really make a big difference in patient outcomes. And so certainly encourage all of you to think about how can we actually connect and coordinate with EMS, because that's an amazing way to be able to get some of these outcomes. Another question came in, said, with data being so diverse, what are the challenges with curating the population health data? Wow, that is, I think that's the essence of a lot of this, is that when you think about how data is organized today, data is organized around fee-for-service billing and collecting for services. Data is not organized around outcomes. Outcomes are very much secondary, if not tertiary. And so there isn't a simple solution for this, as much as over time, as payment shifts, then there's more opportunities to organize the data in a way that is going to be looking at some of these outcomes. I know that if this was simple, everyone would be doing it. It's not simple, It's complicated. And because it's so complicated, and because inherently there's fundamental challenges using systems for billing services for population health, that's why it's difficult to oftentimes scale, and people work on spreadsheets. It's inefficient, drop balls, and it really makes it hard. And what's interesting though is when you look at organizations that don't do fee for service, all they do is risk. They build a very different technology architecture. Their clinicians and their office staff and everybody is logging into different systems that have workflows that make sense, and they're able to get amazing outcomes. So really the challenge becomes one of, how do I maintain the architecture that I need for my fee-for-service business while still actually doing the right things for patients in population health? And that's certainly something, Drew's given, I think, some really great examples of what they're doing at Prisma. And I know that others are doing that as well. We have some other comments, but I think, Anil, you wanted to hop in there.
Yeah, I think it's really important, Brian, for our audience to understand that it's not just about the business constructs that make it difficult. It's really, sometimes it is about the data. To give you a couple of examples, I can give you an ICD-9 or ICD-10 code, and both you and Drew will, recognize that clinical condition right away. But there are no standards, at least no obvious standards that are consistently used to describe some of the social determinants of health that would help us understand health equity and opportunity. So I think one of the most fundamental things is making sure that there is a concerted effort to understanding, are you collecting the data that you need in order to measure and then improve upon health equity? But most importantly, if you're measuring it, how are you codifying it? How are you able to exchange it and share it and all that? Because without that, it's apples and oranges. And I think that's one of the biggest things that we could do as a society is say, as much emphasis as we had placed on ICD-9 codes and CPT codes and ICD-10 codes for billing and documentation, let's put the same concerted effort at creating some standards by which we can start to exchange social determinants of health. And then we may get closer to the problem that you're describing, which is, okay, now, whether you're in a fee-for-service or in a value-based care contract, information is moving so seamlessly that we actually have a chance to get ahead of this. Right now, we're spending a lot of effort just getting the data right. And love to hear from Drew as to whether he thinks we've got the right standards in place for social determinants of health, or whether we still as a society have some ways to go.
Yeah, I love the discussion, Neil. One thought as the question came up was predictive analytics, right? So I think we do a really good job in other sectors, right? So outside healthcare of saying, you know, if you invest X amount of dollars, by the time you retire, you should be in this range, right? And we think about average return, market conditions, et cetera. We don't really do that well in healthcare. And I think that is an opportunity for us to take the data that we're getting for individuals and certainly for populations, and to be able to say, for your chronic condition, which is really hard on a day in, day out basis to say, I don't feel any different with my blood pressure controlled or uncontrolled. I don't feel really that different with my blood sugar 200 versus 120. So it's great to say, well, the risk of you having X condition, we can do this with like the Framingham and some other conditions, but it would be ideal to say that, you know, if you looked at it from a health gratification index, or if you were to say, decades from now, what is the percentage chance of you having, you know, the complications that we typically see in a population with this disease is minuscule, like less than 1%, less than 5%. It may be very motivating for patients and their families and loved ones to say, hey, it's really important that I'm doing the things that I'm doing today to have the health outcome that I want to have years and decades from now. And I think that's where analytics, the data that we're obtaining can really help present that to patients, to say that the trajectory you're on is very favorable, it's very unfavorable, but it's not static, right? So what can you do to position yourself to have the optimal trajectory so that way you are getting the most health benefit for your life expectancy, right? And I think that's where I would love to see that data. I think the other piece of the question that Brian touched on earlier is really, how do we get near real time, right? So you can jump online and see a Google review, Yelp review, all those reviews, but it's a lagging measure, right? To say, well, how was your visit with Dr. Albano? Well, if I don't find out for a month or two that I wasn't doing something that I needed to do, that's an opportunity where I could have taken corrective action and hopefully helped a lot of other patients in the way I presented the information, or the way I listened, or the way I helped with coordinating care. And so getting near real-time data on the back end is really important for patients to be the voice that they need to have and their families need to have to help dictate how we're providing care, right? And positioning them. And so I think that's something we're definitely looking at from a health equity standpoint, is to say, were my questions answered to the satisfaction I needed? You know, did I feel comfortable addressing all the problems I had? I think to your point, Anil, early on is like, why are we waiting till the patient steps foot in our offices to address the social determinants? I feel like that's a parallel lane to the other things that we're caring for in their health continuum, is to say, like, we shouldn't be waiting for you to step foot in the office for your diabetes recheck to say, hey, it sounds like you're having some housing issues or you're having some food insecurity. Like, that should be something that, hey, how are things going with the food insecurity resources we set you up? Do you feel like those are working well for you? If not, let's see if we can get somebody else to help you, or see what other avenues we can pursue. I think that's where we really need to be going with data, is to say, like, we're predicting and being preemptive and proactive rather than reactive, which I think is the traditional model.
You brought up a great point about data. I think what you're describing is thinking about social determinants as being additional vital signs for an encounter. The challenge is, if you talk to clinicians, they're inundated with data. And so being able to take all that information and create some valuable insight would be key. And I think that's where AI comes into play, is that you can take the advanced analytics and start to look at all this data. But some of the work that we're doing around being able to take all that information and summarize it, synthesize it, and serve up the most useful insights to the right person at the right time, given all those things, because it is getting, I mean, we know from clinical practice, and I'm a primary care doctor, as was mentioned earlier, but I'm also a clinical informaticist. You would need to read 27 hours a day as a primary care doctor in order to stay up on the literature. So how do we take all those data points that are being surfaced around social determinants, combine them with all the things we need to do from a value-based point of view, take all the patient factors into consideration, and serve up to the clinicians? Look, this is the most important thing you can do today. It may not be starting the patient on a cholesterol medication. It may be to get them the address for a food bank. So things of that sort. So I love the idea of advanced analytics, but I would probably layer on AI, where it has an ability to make things, to Brian's point earlier, make it simple. You know, how do we make things incredibly simple? Because the use of EHRs is not getting any easier. It's getting more and more complicated.
Yeah, I would just close on this point with the technology we have. It's like you can book a seat on a plane or a table at a restaurant, but it's like, why can't we mirror that in healthcare and make it where patients are using technology as a GPS to help guide them to when's my next appointment? Where do I go for this? You know, where is my drug the most affordable, or can I get the drug delivered to my home? Where do I go for that ancillary therapy, right? Physical therapy, occupational, et cetera. Or maybe that helps with the social determinants, like where is the nearest food bank, or how do I get in touch with them? And so that's where I think technology can really solve that problem for us, is to really position patients to be self-directed, with us serving more as the healthcare advisors, right? Which is what we are, right? We're highly educated healthcare advisors. And what we're doing is trying to advise, and to the point shared earlier, is share in the decision-making with the patient, right? Is to say, what is it that I can do to help you, knowing that you ultimately are the one that's in charge, versus the authoritative kind of direction where it's like, I'm telling you to do this, go do it. And if you can do it, good luck. And I'll see you in a couple months or whenever your next appointment is. And I think we've really got to move away from that model towards more of patient is at the helm of their ship, and we're helping with the compass and the map, you know, and so putting them in a position to be successful.
Absolutely.
I love that compass in the map, and changing the locus of control, shifting it back to the person, but giving them the tools to do it. Because if we shift the control back, but don't give them the tools, it will become an even more frustrating situation. Brian, I think we had one more question, and then we're going to close with Dr. Jain giving us a quick overview of some ideas related to scaling.
Absolutely. And there was a nice comment here about how they're using a portal and integrating pharmacies, and really highlighting, actually, there's a big difference between what's prescribed and what gets dispensed. And so getting actually both data sources turns out to be incredibly valuable, because then you could look and say, okay, here's what we said, but here's what you got, and notice some of those differences. Again, just building on this thematic of how we could be smarter with data and information. And there's great data and information that's available in tools for example, adverse childhood experiences. You know, this is something this is something that was studied by Kaiser and CDC, and we know it, and we know it impacts disease and illness. But as Drew highlighted, you know, patients aren't necessarily motivated by, boy, my A1C is high. It's really understanding what does that patient want in terms of an outcome, and then being able to tie that to the disease and illness. And that requires some different things. And I think, Anil, you're going to help elaborate on that and others.
Yeah, we absolutely have to have the required technology slide. So let's get into it a little bit here. So if we go to let's keep going here.
Yeah, for some reason it's not wanting to advance for me. There we go.
Okay. All right. So I think the most important thing that we can get from this is, we've all heard Drew and Brian, myself, and Amy talk about how this is really a people, process, and a governance issue, and really understanding how things get connected. But at the end of the day, what we need to do is use technology to make it simpler, to enable all this. So once you start to get in data from a variety of different sources, there's lots of data, as Brian just said, around social determinants of health that all need to come together and get organized in a way that we can start to take our various stakeholders, whether it's the community, whether it's the patient, the providers themselves, who have a very important a role in this process, policymakers and payers, as well as the various community benefit organizations, to be able to bring that in and then support the variety of decision-making that needs to happen, either at the population level or at the individual level or even at the community level. But the first step is to get all that data into one place, standardize it, clean it up if it needs to be cleaned up, and then start to create some scoring or some risk assessment process that allows us to be able to, as Drew brought up, predict what would happen if you did not do something. Like if you did not call this patient up and check on them, then they might have a higher risk of readmission, for example. Or if it's a community intervention, can you actually, like I mentioned before, I'm a primary care doc, very, 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 very part-time these days, but maybe the answer isn't a follow-up with me after they get discharged, but a follow-up with a community program out there. So those buckets of prevention, those interventions that we know from lots and lots of studies work, all have to do with making sure the right data is being assessed and evaluated so that the folks can make the right decisions. But it doesn't end there because all that data needs to be tracked so we can actually measure the outcomes. We don't want to be doing the same thing over and over again and recognize 5 years later that it actually doesn't work. This needs to be a continuous learning process and needing to measure the outcomes, figuring out how much of it is coordinating care to make better outcomes, how much of it is actual improved health outcomes versus just improved process. And then my favorite one is reduce cost of care, because I always ask, whose cost? Is it the patient's out-of-pocket cost? Is it the payer's cost? Is it the value-based care contract, CIN's cost? And so on. So let's make sure that we understand that from a technology point of view, it starts with the data and ends with collecting robust outcomes so that we know what we're doing is actually working. And in some cases, even supporting A/B testing, where you don't actually have to do the same thing in every situation. You can do a couple different things. And as long as the science and math is good, you can start to continuously improve the process. And maybe you don't have to wait a couple of years. If you're collecting data in near real time, as we discussed, and you're measuring the outcomes, you can do continuous process improvement. And maybe there are cycles that are weeks long instead of months or years long. If we now go to the next slide.
Oops. I'm actually going to have to stop us because we
yes.
have used all
We
this
have
time
time.
with great questions, observations, and especially being able to feature Prisma and Drew, what you and your teams are working on. It's been especially gratifying to have someone who's both over quality as well as pop health and being the CMO there. You can see how that combination is serving your enterprise very well. We know there were some additional questions in the chat. We hope that this doesn't end the conversation. We have future webinars, conferences. We'd love you to join us, be on our mailing list so that this doesn't feel like a one and done, but you're part of an ongoing conversation with us.
Amy, can I just say that anyone who's interested in that wonderful slide that I was about to present, reach out to us, because I think there's a good story in terms of how we're approaching this, but look forward to following up with anyone. So thank you.
Really appreciate everyone's time in the audience. Certainly appreciate Anil, Brian, and Amy, your time and the opportunity
Absolutely.
to be able to partner with you all today to share our thoughts on the future of healthcare. So thank you.
Thank you, Drew,
so
for your
much.
support. All right. Bye, everyone.
Take care, everyone.